When I see patients in clinic with psoriasis, I usually, when I meet them the first time, I start out by saying, over the next 15 minutes, I'm going to make you into a dermatologist. I'm going to tell you what you need to know so you can manage this on your own. And then you can come to me if you have specific concerns. So over the next 15 minutes, I'm going to make you into gastroenterologists. I'm going to teach you how to do a colonoscopy. No, of course, don't worry about that. But I'm going to give you the insights to have a basic understanding of inflammatory bowel disease and why that's relevant to psoriasis as well. Because there are overlaps, as you will hear, there are overlaps in therapies, and there will also be some therapies that can be problematic there. I'm not going to touch that much upon that, but I'm going to show you some pathways that can give you the ideas. So these are my disclosures, and when we talk about inflammatory bowel disease, this is very much like talking about inflammatory skin disease. So we have two major, of course I know there are others as well, we have two major inflammatory skin diseases, psoriasis and atopic dermatitis. And in the IPC, in the IEC, and all around the world, they've discussed several times, should we think of this as a spectrum or two separate entities? Well, this thought is not that original, unfortunately. The gastroenterologists have done that for many years, talking about Crohn's disease and ulcerative colitis. So in inflammatory bowel disease, you have Crohn's disease and ulcerative colitis that are these chronic inflammatory diseases of the gastrointestinal tract. Collectively, we term them IBD, or inflammatory bowel disease. There are some similarities and there are some differences. So if we look at Crohn's disease, first of all, this is the one that probably resembles psoriasis the most, if you think of it. Very well demarcated, these segmental areas. It's characterized by skip lesions of granulomatous tissue, and it can involve the entire gastrointestinal tract. So starting from the mouth all the way to the anus, everything can be involved, or you can have it limited. It is frequently associated with complications that can be medical comorbidity, or it can be complications specifically to that disease. So think again, psoriasis, a complication there we may think of is psoriatic arthritis or nail psoriasis. They can have complications as well. It is considered relatively static, and that doesn't mean you cannot have flares. I'm going to get back into that as well. But the region that is affected is usually the one that keeps getting affected, the same region. So similar to, you can of course have psoriasis all over your body, but you can have one plaque sitting here in your scalp, and for 30 years that will be the plaque. If you don't treat it, that can still be there. And atopic dermatitis, if you have a lesion, if you don't treat it, then it's like a fire. It will slowly spread. Of course, it can happen with psoriasis as well, but if you think of these two diseases, think of this more similar to psoriasis. Ulcerative colitis, on the other hand, that's a continuous inflammation. So it's more, you don't have this demarcated area. It is the colon that can be affected here, and it's only the colon. So where Crohn's could affect the entire tract, you are limited to the colon with ulcerative colitis. You can also get some complications, but it's not nearly as frequent. So medical comorbidity and also complications specifically to ulcerative colitis is less frequent. And it's more dynamic, and by dynamic I mean you can feel perfectly fine today, and then you wake up tomorrow and you have bloody diarrhea. It is more slowly progressing with Crohn's. So that's where you see some of the differences. And again, trying to draw parallels to atopic dermatitis, you have the flare, you can treat it rapidly in many cases, and the patient feels fine again. The same with UC. When you look at the symptoms of Crohn's, it is gastrointestinal pain that's a dominating symptom. So the patients are complaining about pain. They can have diarrhea, or they will have diarrhea, but they can be bloody, but they don't have to be. So a lot of times it is just watery diarrhea several times a day. It can be 20 times a day, or it could be 5 times a day. And weight loss is often an early symptom. So even before they start complaining about a lot of the other manifestations and the GI pain, weight loss is an early symptom. If we look at ulcerative colitis, on the other hand, it is diarrhea with blood, so there has to be blood. So that's the big difference. Also, there is pus and mucus. And then there is this called tenesmus, which is
the patients start feeling, you know, I need to run to the bathroom. And they rush to the bathroom and they sit down and nothing happens. So the colon is completely empty, but they still feel they have to go. So that's some of the differences. And this is just, you know, dermatologists love pictures. So here you can see how it is. And the difference you really see also is, first of all, that you have manifestations outside of the gastrointestinal tract with Crohn. So you actually have skin involvement sometimes. And you can also have fistulas. And you see this cobblestone configuration of the gut in Crohn's disease, where it's more diffuse inflammation with ulcerative colitis. It can be subdivided in several different ways, and you can look at Crohn's disease and you can say, similar to psoriasis, you can have one single small plaque that just sits there. That is what we have when you call terminal ileitis. You have it at the end of the small intestines, beginning of the colon. Then you can have it different parts of the colon. You can have colon and small intestines. And of course, you can also have it in the upper tract. As I mentioned, a lot of the comorbidity and complications occur with Crohn's. And you can have stricture formation, first of all. And a stricture formation, think of it as like a plumber. You know, he has a pipe and you have some water that has to run through it. If that pipe all of a sudden gets smaller and it gets stiff, less water can pass through it. It's the same here with the food. So you get this stricture, so the intestinal tract becomes very stiff and less food can pass through it. And that means if you eat something that is difficult to digest, it can get stuck, and then you can actually get a bowel obstruction, which can be very, very dangerous. So you can have this with stricture formation. You can also have it where it actually penetrates the gut, and you can have it where it penetrates onto the skin, as I showed you in the picture before. The difference with UC is you don't see that as much. You can have it where it affects part or the entire colon, but that's about it. So it's more simple in that sense. When we look at the disease activity, there are several different types of a disease course you can have. So first of all, you can have what I've termed here as a mild intermittent course. You have this one event with disease activity that can last for a couple of months or weeks or days, and then it goes away, and then you are clear for several years. You don't feel anything. Then it comes back again, you know, small episode, and you're clear again. You can also have it as a severe intermittent course. So you have this severe flare, you may need to be hospitalized, you have severe weight loss, and then you go back into remission, and you can stay in remission for years and years and years. And then you have another severe flare. Then you will also meet the patients that have this chronic activity where they always have, you can have chronic severe activity and chronic mild activity, but it is fluctuating and you will always have some degree of activity. And then you can have the fulminant where you have the very rapid, very severe onset, and these are of course the most complicated patients to treat for the gastroenterologists. You've probably seen a graph like this, very similar when it comes to psoriasis and psoriatic arthritis, where we're talking about, you know, you get these early indications, then you get some hits, and then over time the disease progresses. Well, the thought of that and the idea actually also has occurred for the gastroenterologist. And what they can see is if they look at the inflammatory activity, and I'll come back to that at the end of my talk, what that means, but you will have some inflammatory activity around the time where you get the diagnosis. When the disease starts, it's much more subtle, so you will not always catch it that early. There is a diagnostic delay. But then you get this flare of inflammatory activity, and then the disease slowly progresses. Then in early disease, you may get a stricture, and then you may start developing these fistulas and abscesses, and at one point you may need surgery. And then over time, again, more stricture, more complication. Of course, this is something that the gastroenterologists are trying to curb with their treatments as well. But it actually looks, if you look at the data for the past 20 years, the proportion of patients that need to be treated with surgery has not changed in IBD, unfortunately. So why are we spending so much time talking about IBD when this is a psoriasis symposium? Well, it is because there is a very close relationship
between psoriatic disease, meaning psoriasis and PsA, and inflammatory bowel disease. So first of all, you have a lot of genetic susceptibility that is shared. So if you look here, you can see the IL-23 receptor, for example. There's also TYK2. And this, first of all, here will give you an idea that we may have some treatments that could work in both. So targeting, the JAK-STAT pathway or targeting IL-23 may actually be beneficial in both areas, where, as we know from clinic, IL-17 inhibition can sometimes be more problematic. There's also predisposing factors in the skin and gut barrier, and they're very similar. And when we actually look at it, some of the trigger factors for psoriasis, stress, the Kipner phenomenon, and so on, very similar things tend to occur, and infections can also trigger IBD. So very similar between psoriasis and PsA. And then there is this mechanical stress that leads to the inflammation, and this is again shared both between psoriasis and inflammatory bowel disease. And I'm saying IBD collectively because it is a bit different between Crohn's and ulcerative colitis, but a lot of it is actually still shared. So what about our patients? Because we are dermatologists. Should we be concerned, and who should we be concerned for? Well, we are actually able to look at data, and we're actually able to see which of our patients have the highest risk of Crohn's disease and ulcerative colitis respectively. And interesting, if you look at the psoriasis population compared to a general population, the incidence of IBD differs with sex and with age. So for example, Crohn's disease, it is actually women, and it's the younger women that have the highest incidence of Crohn's disease compared to non-psoriasis women. Ulcerative colitis, on the other hand, is a bit different. It is men that have the highest incidence, and it is both in the, in their 30s, 40s, but also in the 70s, 80s, and so on. So that actually tells us in clinic when we screen, what should we look for and when should we look for it? So the question, of course, is should we be concerned about this? Is this an epiphenomenon? Is this a real risk? So when you look globally at all the studies published and you do a meta-analysis of them, we can actually see how many of our psoriasis patients have IBD and how many of people with IBD that actually have psoriasis. And the interesting thing is, first of all, we shouldn't go and scare all of our patients because the prevalence is still low. It's about 1% of our psoriasis population that have inflammatory bowel disease, 1.2 if you do this meta-analysis. You can see the prevalence is slightly higher for Crohn's than for UC, but what is really interesting here is actually if you look at people with inflammatory bowel disease, and especially children with IBD, they have a very high prevalence of psoriasis. So it's actually more in the children with IBD that our attention should be focused, are they starting to develop skin lesions? Up to 8.4% here, you can actually see, of children with IBD have psoriasis. But this also tells you something important about clinic, because here we can see the vertical line at time 0. That is when patients are first diagnosed with psoriasis. And when you actually look at the time between diagnosis of psoriasis and when they get their IBD, most patients have had IBD for several years, 5, 10 years before they're diagnosed with psoriasis. Again, this leads back to the fact that it is more prevalent to have psoriasis in children with IBD because they get IBD very early. But this also tells us as dermatologists that we are overwhelmed with comorbidity that we need to focus on. Depression, cancer, cardiovascular disease, psoriatic arthritis. But here we can actually see that doing a thorough screening at the first visit, that's the most important part, because the vast majority will occur at that point, that they already have it. So my last slide is about the practicalities. What should we do? Because as we know, there are some things that we should do, and there's a lot that we're uncertain about. So what should we ask our patients about? Well, first of all, a family history. Psoriasis runs in the family, but so does IBD. So asking about family history, asking about the symptoms. So first of all, chronic diarrhea, watery stools or bloody stools several times a day. chronic abdominal pain, rectal bleeding, weight loss, and persistent fever. These are some of the things where we should start to think, could this be because the patient actually has inflammatory bowel disease? If you look at the medical charts and there's a history of fistulas or abscesses, then this is also a giveaway. And of course, if you find anemia, we need to dig a bit deeper, because this is, anemia in these chronic diseases that's very common in IBD. So if you suspect, what should we do? Well, first of all, do inflammatory markers, the blood levels, and see the CRP. You can also do fecal calprotectin. It's very, very easy to do. It's a stool sample you send to the lab and you get it back. Less than 30, you are in the clear. 30 to 300, it's probably not, but you need to be cautious. More than 300, then that's where you really need to be worried. And whenever, you think of this, also think, could it be an infection, gastroenteritis? But if you are in doubt, similar to psoriatic arthritis, if you don't know what to do, ask our friends in rheumatology. Whenever you don't know what to do here, of course, ask your local gastroenterologist, because they are the experts in the same way that we want, them to ask us about psoriasis. Thank you so much.
That's a really wonderful talk. Are there questions, just any key points in the presentation?
For exclusion of IL-17 blockers, obviously if they have IBD, but family history of IBD, would you say don't use an IL-17 blocker in that type of patient?
That's an excellent question, and it's something that that's actually tried to be studied. Is the incidence higher there? The short answer is, if you say, well, I have a family member with IBD, no, I would not exclude an IL-17 inhibitor there. But I would say, give the patient advice. So if they start noticing these things, they shouldn't wait until the next consultation. If they start to notice similar symptoms, then call. But the good thing is, usually when you have a family member with IBD, you are already aware of the symptoms. But having a family member, in itself should not be an exclusion to give a patient an IL-17 inhibitor.
There's one question there. Can you speak up, actually? Sorry, it's because we can't. We'll come to the microphone. Thank you.
Talk. Congratulations. So again, about the same topic, do you tend to use some standardized questionnaires like CalProQuest for screening of your patients apart from just the clinical questions, or
to screen
for
for
IBD?
IBD?
Yeah.
So generally, what I tend to do is, first of all, I ask patients. Luckily, we have a very close collaboration with our gastroenterology colleagues, because I have some of them that are very interested in this overlap. But what I tend to do is I ask about the weight loss, the pain, and the diarrheas. And then if anything there, sometimes I will say, if it's blurry, I'm not completely sure I should refer, then I do the calprotectin. Otherwise, I refer them directly. So no other screenings than those 3 questions. And again, it's also a matter of time in clinic. We are very busy already.
Thank you for that, because I tend to use the CalProQuest questionnaire, to be honest, and depending on the score, then I'm doing a calprotectin or not, or I will refer to the gastroenterologist later. But thank you very much. Thank you, and congratulations.
Okay.
Hello, another question regarding the onset of IBD during IL-17 blocker treatment. Is there a risk profile, so certain patients where you would avoid the IL-17?
So you are thinking a patient without any existing IBD, but is there a specific risk profile? There's not something where I would avoid it, because we don't have those specific predictors yet. But what I would say is, I know, as I showed you the data, you can see which groups are the highest risk. So for example, for Crohn's disease, it was the young women that had like a 4-fold higher incidence. So in these, I may be more attentive, and I will say to them, if you start experiencing symptoms, but we don't have any predictors to say that this patient should be switched to a TNF or an IL-23 rather than an IL-17. We don't have any good predictors at this moment.
Okay.
And the reason for this is also, just to follow up on that, is that when we see IBD associated with IL-17 inhibitors, it is not always the classic IBD. It tends to have a bit atypical presentation as well, similar to when we sometimes, we do a punch biopsy and the pathologist will say it's psoriasis-form dermatitis. It's the same. The IBD tends to be a bit different, so it's not as clear-cut yet why this occurs.
And how is the course of IBD that was triggered by IL-17 antagonists?
That is
If
triggered
it's
by
different-
this.
So if it's different to the classical forms of IBD, so how, in what way it differs?
First of all, it will depend if it's UC or Crohn's disease. You can have, of course, you can have some of them that gets better when you discontinue therapy and you switch to another, another biologic that will actually treat it. But you can also have some of these that can be very, very difficult to get under control again. But we should also keep in mind that it's not, if you give 100 patients with IBD, if you give them an IL-17 inhibitor, it's not 100% of those patients that will flare. It's a large proportion, but it's not everybody. So that's why there's no clear-cut answer. So it's similar to psoriasis. We do have some patients with psoriasis where, they get prednisolone, and not all of them, they have COPD, exacerbation, they get prednisolone, they're tapered off very, very quickly. Not all of them get pustular psoriasis. So it's the same with the IL-17 inhibitor. It's not everybody that gets IBD or worsening.
Thank you.
Okay.